On behalf of my co-authors, I'm pleased to present OnabotulinumtoxinA is efficacious and well tolerated in male patients with overactive bladder and urinary incontinence. Placebo-controlled treatment cycle 1 results from a pooled analysis of 4 randomized trials. This slide shows my financial disclosures. The majority of patients in clinical trials of OnabotulinumtoxinA for overactive bladder with urinary incontinence have been female. So there's limited data on the efficacy and safety of OnabotulinumtoxinA in males. The aim of this study was to evaluate the efficacy and safety of OnabotulinumtoxinA in males with data from 4 randomized clinical trials that were pooled. These trials were conducted in North America and Europe and tested OnabotulinumtoxinA versus placebo in patients with overactive bladder with urinary incontinence that was inadequately managed by at least 1 anticholinergic medication. These included 2 registration trials, a phase 3B trial, and a phase 4 post-marketing trial. Assessments included change from baseline at week 12 in urinary incontinence episodes, incontinence quality of life score, and treatment benefit scale during treatment cycle 1. Safety data were also reported. Data from the pooled population were split into males and females. There were 194 males in the pooled intention to treat population. Demographics and baseline characteristics were generally similar in males and females, with the exception of OAB duration, which is about 2 years longer in females. Improvements in urinary incontinence episodes per day were seen with OnabotulinumtoxinA treatment in both males and females, with high proportions of patients achieving greater than 50% reduction in urinary incontinence episodes per day at week 12. The magnitude of the improvements in females does appear to be greater. Similarly, improvements in healthcare outcomes, I-QOL, and treatment benefit scale were seen in both males and females with OnabotulinumtoxinA treatment, but again, were somewhat greater in females. In terms of treatment-emergent adverse events in the first 12 weeks after treatment, the overall incidence was actually higher in females than in males in both OnabotulinumtoxinA and placebo treatment groups. This is especially seen in the incidence of urinary tract infection, which was considerably higher in females, 13.1% versus 4.2% in males. And this may be expected since females are more prone to developing UTIs than males are due to commonly recognized risk factors and anatomy. Not surprisingly, hematuria was a more common adverse event in males and occurred only in males, about 6.8%. That was likely associated with the actual procedure of inserting the cystoscope through a longer urethra and the prostate. Urinary retention was reported at a slightly higher incidence in males compared to females, 4.7 versus 2.7%, possibly due to the male anatomy. Also, it should be noted that retention rates were similar in males in the onabotulinumtoxin and placebo groups, again speaking to the fact that at least some of that retention may have been caused by the procedure and not necessarily the OnabotulinumtoxinA. In conclusion, this pooled analysis of 4 randomized clinical trials of OnabotulinumtoxinA, 100 units for overactive bladder with urinary incontinence, found clinically meaningful treatment benefits in all efficacy measures, including quality of life in both males and females. The overall adverse event profile was generally limited to local urological events and no new safety issues were identified. OnabotulinumtoxinA was efficacious and well tolerated for the treatment of overactive bladder with urinary incontinence in both males and females. Thank you very much.